All right. I think we're at a quorum now, so we are good with that. Just a couple reminders, we are being recorded, so just keep that in mind. Please mute your line if you're not speaking so we can eliminate background noise. And I will go through and drive the agenda for us today and defer to Dr. Ott as we do any voting, and we'll do the usual roll call voting. You can aye, nay, or abstain. With that, I think we are good. I know OMPP is ready. Dr. Ott, are you ready?
I am. Can you hear me? Sorry.
Yeah, you're all good. All right, with that then, I will turn it over to you for the call to order and the remarks.
Well, I don't have any specific remarks, but I welcome everyone to the September DUR board meeting, and we will call this to order.
Thank you. I have been informed that there are no opening remarks from OMPP, so we can then move on to the approval of the minutes from the August meeting.
Do you need me to call a vote?
If I could get
to approve, Dr. Marshall.
This is Beth, I second.
All right, we have a motion and a second. So Dr. Ott.
Aye.
Ms. Phippen.
Aye.
Dr. Hart.
Aye.
Dr. Marshall.
Aye.
Dr. McCarty.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. We will then get into our agenda on our updates and PA stats. So for our PA stats for August, overall we had 81% approved and 19% denied. So we are just a little over 20% approved and just shy of 5,000 denied. When we look at the manual PA versus the point of sale quick check or the automated PA, we had 84% approved through the automated PA, 16% denied. Of those that were denied on the automated PA, 24% went to the call center, where 81% were approved and 19% denied. And we had a straight 50-50 split on the manual PA side. And if you look at our trending graph overall, very steady. We had that slight decrease a little bit in August, but we did have a pretty robust increase in July, especially around stimulants. So we saw that come down just a little bit, but still higher because we are again in the back to school month. So kind of what we would expect to see when we're looking in August, but fairly consistent. In the top 10, again, we had the stimulants still pretty high up there. And then clonidine, guanfacine, and antipsychotics. So you might notice that clonidine, guanfacine jumped up, and that's because we did make some changes to that PA as well as back to school. So we're kind of double whammying it at the same time there. And then, so the opiates were in the fourth, which is a little bit of a change up for us, but not super significant. And then on the manual PA side, we had the GLP-1s in the top position along with early refills, and then the agents for the treatment of cystic fibrosis. That one tends to be pretty cyclical. So every once in a while, we have like a bulk of PAs come through and we see that come a little bit higher. Any questions on that? All right. Apologies for the sniffles. Both Courtney and I are sneezing. I think there's mold in this room or something. We need to clear that out in the state building. All right. For the opioid stats for August, we had a decrease in July, just slightly on total utilizers and a little bit more on new utilizers. And for the 18 and under, fairly consistent. Again, the average day supply being about 4.57 days. So right under the 5 days, which is where we like to see that stay. You'll see that, again, we have nobody over 500 that is not PA exempt utilizing. We're still working through the 250 to 500. We're at what, 3? Are we still at 420? 325 in October. 325 in October. 350?
We're at 3 right now.
Do I hear 375? We're at 350 right now. We will be going to 325 in October. So we're still working in that 250 to 500 range, but you can see we have decreased that down and that there is a fair amount that are PA exempt, and then just kind of a smaller number that we're continuing to work through. So if we look at our above 90, again, pretty small numbers. Most of our people are in the less than 90. And then if we look at the overall trend, you'll see really fairly steady. We, again, had kind of that downward trend in the later part of last year. And then in the first part of this year, kind of a little bit of a slight uptick, but not super significant. And then we've held pretty steady here now, kind of for the past several months. So really no significant change in those stats. And then again, you can see in the less than 90, really, really steady, almost flat line since beginning of the first of the year, or end of last year rather. And then this has the 90 and above. And so you can see there is a slight increase in the 90 to 120, not super significant. Again, these are really small numbers, but overall, everything that we expect to see is what we're seeing. That 500 to 750 and greater than 750 have been very consistent. It's the same individuals throughout. And then that 250 to 500 has also been relatively steady, but we'll probably see another decrease as we continue to move people through. Any questions on the opioid statistics? All right, we will go straight then into our opiate overutilization provider review. So this is where we review for those number of prescribers for anybody that have been getting 5 or more prescribers, just to make sure that we don't have any issues with that. So we review this by 60-day time periods because that's how we check for those 5 or more prescribers. This is probably less impactful than when we look at the actual graph. So we had January to February that we reviewed, March to April, and then May to June. You can see those numbers there. And then again, the vast majority of the people are falling in that less than 3 prescribers, which is the green there, just a small number that are in the 3, 4, and 5. And usually what we find, those individuals that are in the 3, 4, and 5, they're often coming from prescribers that are out of the same office, and they're just seeing somebody different at that time. So again, this is doing a comparison between kind of different 60-day time periods to see if there's persistence between some of our people that utilize more than 5 prescribers at any given time. So you can see there was one individual here that had utilized 5 or more prescribers, but otherwise the vast majority in the less than 3. When we did the March to May, we had 2 that fell into that group. And then when we did the overall compare, it was just that one person that kind of maintained throughout. Otherwise, everybody else was in the much lower groups and not really concerning. We do tend to have one person that always falls in there, and usually they're oncology patients and patients that have pretty significant disease states that they're working towards and managing. Any questions on any of that data? Any concerns? And I'm going to ask it every time because I do. Is it something you would like to continue seeing as far as data? So we've continued to have, I would say, very consistent data, but we are happy to bring it back to you again in 6 months if you would like to see it in 6 months. Or 1 year. Sorry, we do it annually. Annually. I'll bring it back to you in a year.
Okay.
Yeah. I'm in favor.
Okay, we will continue. All right. This is from the therapeutics committee. Kind of look at, and specifically around it. We will ladder those utilizing both for a very long the new starts in the PA, but we haven't really looked at those that have just been kind of continuously using. So we are trying to bring that forward in a retro DUR and have some information for you. So just as FYI, I mean, I think most of us know this, that the FDA in 2016 did announce that they were requiring a class-wide drug labeling that includes patient information to let people know of the serious risk associated with using both opioid and benzodiazepines together. And they can pose serious health risks used together. Dizziness, lightheadedness, extreme sleepiness, slow or difficulty breathing, coma, and even death. So it's certainly something that we see fairly often in overdose deaths are people using multiple products. The FDA has also required an addition of a box warning and patient-focused medication guides for prescription of opioid analgesics and cough products and benzodiazepines. And the box products are around co-prescribing as well as utilizing with alcohol, and that it can result in all those things that I just mentioned before and potentially death, and that it should be reserved in only those individuals that there's not alternative prescribing for. So again, most of this information, I know you all are aware of that. Just to kind of give us some statistics around this, in 2021, 14% of the overdose deaths involving opioids also involved benzodiazepines. And then amongst patients who did not have an opioid use disorder, those who received concomitant benzodiazepine and opioid prescriptions had a higher mortality rate than those who received one or the other. 33% of patients with confirmed opiate overdose presenting in the ED also had concomitant benzodiazepine exposure. So again, we're seeing a lot of concomitant use, whether with benzodiazepines or other therapies that can lead to overdose. A retrospective cohort study found that between 2014 and 2018, approximately 23% of commercially insured and 26% of Medicare patients had overlapping opioid and benzodiazepine prescriptions. So large number of patients, and Medicare patients, we're talking about older patients in general, which puts them even at further risk, which was something that Dr. Shaw really wanted to bring forward to the group, is that what he is noticing is that because there are not some of the same prescribing practices, restrictions in long-term care, that he's seeing a lot of concomitant prescribing, and he's having a really hard time being able to decrease or remove somebody's benzodiazepine or somebody's opioid, depending on the situation. A lot of times he's working with another prescriber, and that other prescriber is very resistant. And so he wanted us to kind of take a look at that and see if there were things that we could potentially do to address that. A retrospective analysis of Medicaid claims from 2014 showed that a larger portion of non-Hispanic whites, those 50 to 64 in Medicaid, had higher rates of co-prescriptions of opioids and benzodiazepines compared to other race and groups respectively. Just as a FYI there. So if we look at our specific data, we pulled January 2025 through June of 2025. So we're looking at a 6-month time frame, and just because there's a lot of claims that we're looking at when we're looking at these. So during that reporting period, we had a little over 4,000 members that had either a claim for benzodiazepines or opioid therapy that was longer than 7 days. And then when we looked at all of those members to see who had concomitant use, we had 177 members. So actually better than I thought it was going to be in all reality. Now, what I would probably argue and say, because I'm maybe a little jaded, is that we probably have way more than that are getting it cash and not getting it through our benefit. So we're just not seeing it. But through our benefit, we had 177 members that had greater than a 7-day supply. 22.6% of those individuals were either 40 or under, and then 77.4% were greater than 41 years. So again, we're talking more of our older population, or getting into that older group. And so then we did a breakout by plan, because again, Dr. Shaw was very concerned about long-term care. And so in our breast cancer plan, we had 14 individuals. The regular fee-for-service plan was where the bulk of our individuals were, 147. We had a very small amount in the long-term care plan of 7 individuals. And then in our presumptive eligibility, we had 9 individuals. So what I would say is, I know you're probably looking at these numbers and thinking they're really small and thinking, well, maybe what is Dr. Shaw talking about? Because he's saying all these long-term care individuals are on this. This is just for fee-for-service, remember. This does not include any of my lovely managed care partners' data. And so at some point, that may be something that we will try and partner with them on to take a look at for this retro DUR. They're giving me some fun looks, because everybody loves to try and look up concomitant data usage. It's a really fun report to run. So please keep that in mind, that it's more than just the fee-for-service population that potentially is impacted. So while the numbers may be small, they are probably larger throughout the rest of the group. So that brings us to our red charter proposal on benzodiazepines and opioids co-prescribing. The rural properties, we would like to look at all ages and both genders, all prescriber types, no defined diagnoses, just if you're using for greater than 7 days of benzodiazepine and opioid therapy together, because you might remember 7 days is the allowance that we have within our PA for new starts. So this is going to be looking at more of those individuals that have been having some long-term utilization. No negating diagnoses, and no negating drug therapy. And then from an outcomes measure perspective, we're going to be looking at a decrease in the number of individuals that are co-prescribed benzodiazepine or opioid therapy, or basically looking to see, did somebody have a benzodiazepine or opioid therapy that was tapered and discontinued, which we will make sure that we include in our newsletter topics, which go along with the red charter proposal. So the main topic will be about benzodiazepine and opioid co-prescribing. And then the secondary article will talk about benzodiazepine tapering when the risk outweigh the benefits. So really trying to focus in on ways that individuals should taper and taper appropriately, because the last thing we really want somebody to do during this red charter is all of a sudden say, hey, we're going to stop your benzodiazepine you've been on for 15 years. Have fun, let us know how it goes. So we want to make sure that people are doing it appropriately and that they're choosing the right patients to do that in. I know I just said a lot. Any questions, comments, concerns? If not, if I could get a motion and a second for approval of the red charter and the newsletter topics, please.
So moved.
I didn't catch who was the first person in that motion?
Hart, so moved.
Oh, thank you. And do I have a second?
Second, Dr. Marshall.
Thank you. All right, I have a motion and a second. Dr. Ott,
Aye.
Ms. Fippen,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCarty,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
Thank you. We have all ayes, so that motion will carry. So at next month's meeting, we will be bringing you back the newsletter as well as the Dear Doctor letter for you all to review before we initiate this red charter. Thank you. All right. That takes us up then to update with managed care pharmacy. Any update from the ladies in the room? Any update from the folks on the phone? I'm hearing none. So I think we are good to continue then into our new drugs. We have a lot of big words today, so button up. All right, we have our phenylketonuria agents, Kuvan, Javigtor, I think is what we're thinking, and Zelvicia. So these already have PA criteria, but we're updating the reauthorization criteria pre-bill duration to 6 months instead of a year to be consistent with the other agents. And then updating the initial authorization criteria to include a baseline blood phenylalanine level prior to initiating therapy, and then updating the reauthorization criteria to include submission of documentation supporting reduction in blood phenylalanine levels. And then updating the criterion regarding the use with other hyperphenylalaninemia, too many A's, reducing agents to include cefians. My apologies. Trying to say an enemy here apparently, and I'm really struggling. All right. The next drug, Palynziq, hooked on phonics, folks. Updating the initial authorization criteria to include the documentation of the baseline blood phenylalanine levels, and then updating the reauthorization criteria as well, and that the prescriber has submitted medical justification for continued use of those individuals that are not exhibiting a reduction in blood levels. There is a long trial and titration periods in the prescribing information, so this one's a little different than the one prior. And then again, updating the same criteria regarding use with other agents to include cefians, which is a new agent that I have on this slide. So cefians, its initial authorization is approval duration for those 1 month of age and older. and less than 2 years of age is up to 6 months. And then for those 2 years of age and older is up to 2 months. They have to have the diagnosis of phenylalaninemia due to sepiapterin, I think we're right. Sepiapterin responsive. You would think I didn't practice this, and I legitimately did, but I've forgotten since then. For phenylketonuria, documentation based on their blood levels obtained within 30 days, and then member is 1 month of age or older. Prescriber attests that they are going to adhere to the phenylalanine restricted diet. The member has not been and will not use Cefiance in combination with Palynziq and other agents in this group. And then previous trial and failure of an agent at an optimized dose of 20 milligrams per kilogram per day for at least 30 days in the past 60 days, as supported by claims history or chart documentation, and then or medical justification for why they need to use Cefiance over the other agents. And then the dose requested will not exceed 60 milligrams per kilogram per day. And then the reauthorization criteria will be history of the requested agent for 45 of the past 60 days is confirmed by claims history. Again, that they've had the reduction in phenylalanine blood levels, and that they're continuing to attest that they're not using with other agents and that they're still on the restricted diet and that the dose is still the same. Any question on those agents? As long as it doesn't involve me having to repeat words that I can't say, I would greatly appreciate it. All right, if I could have a motion and a second for those, please.
Is there a motion to approve?
Hart, so moved.
Skelly, I'll second.
All right, I have a motion and a second. Dr. Ott.
Aye.
Ms. Pippin.
Aye.
Dr. Hurt.
Aye.
Dr. Marshall.
Aye.
Dr. McCarthy.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. That then takes us to liaison with other boards. Any liaison information? All right, hearing none, that takes us to old business. Any old business? Also hearing none, takes us to new business. Any new business besides the long list that I have on the agenda today? All right, let's get to it. All right, so for our amyloid beta directed antibodies, Aduhelm updating its initial criteria duration to state up to 9 months. It was previously at 8 months. And then reauth criteria to include a comparison to baseline verbiage and associated documentation requirements. So we're just trying to standardize some of the language across this group as we make updates. For the Kisunla, updating the initial authorization again to the 9 months. Update the quantity limits to reflect an update in dose initiation and modified titration. So they have 3 infusions consisting of a modified titration every 4 weeks, followed by the 1400 milligrams every 4 weeks. And then again, updating the reauthorization criteria similar to Aduhelm. For the Leqembi IV, updating its initial reauthorization to 9 months, and then after that, in the reauthorization, it would be up to a year. It was previously 8 months. And then again, same reauthorization criteria around comparison to baseline. And then also to the existing reauthorization criteria, adding one of the following: member has been on requested therapy for less than 18 months, or member has been on requested therapy for greater than 18 months, and prescriber has submitted medical justification as to why the member cannot transition to the subcutaneous formulation Leqembi, which is what we're going to discuss next on this next slide. So this is the Leqembi subcutaneous formulation, and so we are recommending adding PA criteria to that, which is going to be fairly consistent with the IV. So the approval criteria duration is up to 1 year. They need to have a history of Leqembi, the IV formulation, or a history of the Leqembi subcutaneous formulation within the past 60 days. and that the member has received at least 18 months of consistent Leqembi IV formulation as confirmed by claims history or chart documentation, noting their dates of infusion, and or that the member has previously been approved for the subcutaneous formulation. The prescriber has provided updated documentation of clinical improvement or stabilization when compared to their previous scores. The dose does not exceed 360 milligrams every week. And then that the prescriber has submitted documentation of decreases in amyloid beta plaque levels as compared to baseline. We go through all the ways that you can do that, and it's consistent with the other Leqembi criteria. So it's after the 7th dose and at 18 months after initiating therapy, and then every 18 months thereafter. And then approval criteria continued is that they state that they will remain a candidate for treatment, that they haven't developed any of the exclusionary, which includes risk factors for intracerebral hemorrhage, which all of those are listed there. Again, similar with the IV formulation. They history of antithrombotic agent or other than aspirin or clopidogrel with plans to use concurrently with Leqembi, and then any other neurological or psychiatric condition that may be contributing to their cognitive impairment. Any questions on the amyloid beta directed antibodies before we go on to the next group? All right, so for the complement inhibitor agents for Empaveli, updating its initial authorization, they just received an indication expansion. And if you thought my words were fun before, I get to be really fun now. A diagnosis of C3 glomerulopathy or primary immune complex membranoproliferative glomerulonephritis confirmed by renal biopsy or confirmed by one of the following, and this is for adolescents only, and then we list those various serum levels. And serum C3 below normal limit, and or presence of active urine sediment, or C3 nephrotic factor, within the past 6 months. And then they also must have submitted documentation supporting that their eGFR is greater than 30 mils per minute. They have proteinuria greater than 1 gram per day, and their urine to creatinine ratio is greater than 1 gram per gram. And then member is 12 years of age or older, and one of the following, that the member has utilized ACE inhibitor or ARB therapy at a maximally tolerated dose for 90 of the past 120 days, and that they will continue using that agent, or that they have provided medical justification for why they cannot use those agents or continue. And then updating the reauthorization criteria to include the eGFR and UPCR documentation submissions supporting stabilization and improvement in clinical response. For Episcally, we're updating criteria to remove step therapy through Ultomiris. And then Fabhalta, updating criteria for complement 3 glomerulopathy indication to state that they have utilized angiotensin converting enzymes or ARBs, similar to the other criteria I just mentioned before, and that they'll continue to utilize that therapy, or that they have justification for use as to why they cannot, just making it consistent with Empaveli. Any questions on that? Okay, for the Cushing syndrome agent, metapyron, updating its quantity limit from 4.5 grams today. All right. Don't get All right, so Ozempic attestations for initial authorization for the MASH MASLD and consistency with our other criteria that we're putting in place, and then adding reauthorization criteria on the MASH MASLD indications that they have documentation of current clinical status through a liver biopsy that they've done, or by or scan result demonstrating that they're seeing some stabilization. For Zepbound, adding a reauth criteria that they're not using Zepbound concurrently with another GLP-1 receptor agonist or combination product. And then Wegovy just recently received the MASH diagnoses, so that's what we're really adding here. We have an organization for a diagnosis of MASH, and that they're 18 years of age or older. This has been confirmed through a liver biopsy. That's where there for you. Or they can have a fiber scan, and again, with the results there. It needs to be prescribed by or in consultation with an endocrinologist or hepatologist. And then a member will not be using Wegovy concurrently with Rezdiffra, or the prescriber has provided valid medical justification for the current use of concurrent use of Wegovy and Rezdiffra, so that will be reviewed on a case-by-case basis. And then the member does not have type 2 diabetes. If a member has type 2 diabetes with MASH and has utilized Ozempic at 2 milligrams per week consistently for at least 18 months and has demonstrated inadequate reduction in fibrosis confirmed by a liver biopsy or the fibro scan, then we can look at going to this high dose with Wegovy. So just to try and make sense of that, either they don't have type 2 diabetes or they do have type 2 diabetes and they've trialed Ozempic at 2 milligrams per week consistently for up to 18 months, and then they're still not seeing results and they really need to go up to potentially that 2.4 milligram dosage, then we would look at Wegovy. Again, they won't be using it concurrently with any other GLP-1 receptor agonist, and that the prescriber is attesting that they will use Wegovy in combination with a reduced calorie diet and increased physical activity. And then the reauthorization criteria will also include this expansion of MASH, and that again, that they're providing documentation of current clinical status. As we mentioned before, they're not utilizing it with another GLP-1, and that they will continue to utilize in combination with a reduced calorie diet and increased physical activity. Any questions on those updates around MASH? Silence is golden. I love it. All right. We're almost there. We're getting there. Slowly but surely, we're getting there. All right. On the non-SGPDL agents, PA and step therapy, Kerendia recently received a label expansion as well. So we're updating their criteria. And this is around a diagnosis of heart failure with left ventricular ejection fraction of greater than or equal to 40%, and New York Heart Association class 2 through 4 symptoms, and their eGFR is greater than or equal to 25. And then the supporting documentation for that. They should have a serum potassium level of less than or equal to 5. They need to be 18 years of age or older. And then we're going to be looking for a trial and failure with either spironolactone or eplerenone after their diagnosis of heart failure, or that the prescriber has submitted medical justification for use over those agents. And they also should be receiving an SGLT2 that they will continue utilizing while they're using Kerendia, or they've submitted justification as to why they cannot do that. The prescriber is attesting that they're not going to use Kerendia with any other mineralocorticoid receptor antagonists, and that the dose requested does not exceed 40 milligrams per day. And then for their reauthorization criteria, again, adding this new diagnosis of heart failure, and that they've utilized the agent within the past 90 days, that they're continuing to utilize it with an SGLT unless they have other SGLT2, unless they have other rationale as to why they cannot, and that they're continuing to not use it with other mineralocorticoid receptor antagonists, and that again, the dose is the same. And then adding a quantity limit of 20 milligrams per day for the chronic kidney disease and type 2 diabetes, just so we have the quantity limit consistent in both indications, since we have the 40 in this and it's 20 in the CKD. And then also adding the requirement for the serum potassium levels to be less than 5 prior to initiating therapy in the CKD and type 2 diabetes indication. All right, any questions on that? For the thrombopoietin receptor agonist agents, Doptelet updating their authorization criteria around a label expansion. So it's diagnosis of persistent immune thrombocytopenia or chronic ITP, and that they've had insufficient response to corticosteroids, immunoglobulins, or splenectomy, and then that the member is 1 year of age or older or less than 18 years of age. All right, now we're into the easier stuff. So some SGPDL updates. Under MS, the Empira brand is being moved to non-preferred and maintaining the PA criteria with the respective quantity limits. The generic is on the preferred side, so it's still available. It was just the case that both were on preferred, so now we're flipping the brand to non-preferred. This is informational only on the skeletal muscle relaxants, but the Levispa is, they're having issues with supply. And so we moved all of our baclofen oral solutions over to preferred with the do we need to move? Well, sorry, our lights just went out. We got mood lighting in the room for some reason. But updating that so that we have those agents available since there's current issues with yep, there we go, Levispa formulation. Put everybody to sleep so nobody's moved and our lights went out on us. All right, we did recently have some NDA withdrawals and coverage termination of some products, which was interesting. That was effective 9/3/25. So this is informational only, but Bydureon, B-Size, Byetta, ibuprofen, famotidine, lev-amlodipine, Osmolex ER, and Zithromax and azithromycin 1 gram suspension all had their NDAs withdrawn. They are no longer allowed to be marketed currently. I have no other comment or thought around that at this moment in time. All right, vaccine edits, informational only. So for the COVID-19 vaccines, the Pfizer vaccine for 6 months to 4 years of age, removing from coverage due to the FDA revoked their emergency use authorization. The next spike adding to coverage for VFC pharmacies 12 years of age and older and non-VFC pharmacies 19 years of age and older. And then VFC and non-VFC pharmacies, the FDA Center for Biologics Evaluation and Research announced that they suspended the biologics license for IXCHIQ. So you might remember we've gone back and forth on IXCHIQ now for like the past 3 or 4 months. It's covered, it's not covered, it's restricted in use, and then it's not restricted in use. And they have had a hard time deciding. And right now they have decided to pull it. So we have made it no longer reimbursable through our group, and it wouldn't surprise me if I come back next month and tell you something completely different. So hang on to your hats and we'll see what happens. Preferred brand list updates, Adzenys XR ODT adding, as well as Traclear dispersible tablet and Benifer. And then removals from the preferred brand drug list include Cloderm cream and Motegrity tablets. We made it. That's the rest of the new drugs. Any questions, comments, concerns on that?
Nope. Impressive. Thank you, Amanda.
Thanks, Kelly. Could I have a motion and a second, please?
Move to approve, Dr. Marshall.
Second. Go ahead.
I'll take Petra. I saw her highlight first, so I'll take her for that one. All right, I have a motion and a second. Dr. Ott.
Aye.
Ms. Whitman.
Aye.
Dr. Hart.
Aye.
Dr. Marshall.
Aye.
Dr. McCarty.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
Thank you. We have all ayes, so that motion will carry. That will take us then to our public comment. Let me try and get my clock up here really quick. But while I'm doing that, our first up is Mark Borns with Empaveli.
Hey, good morning, everyone, and I'll make it easy for you on the clock with this one. Joined on behalf of Apellis Pharmaceuticals. You guys just reviewed and discussed Empaveli's new indications in rare kidney disease a few minutes ago. I'm aligned with the clinical recommendation and the criteria that you displayed, so I'm happy to give the rest of my time back to the board. Thank you very much for your attention.
Thank you. Next up, we have Dr. Patel for Kerendia.
Hello, everyone. I'm Pranav Patel. So I'm here on behalf of Bayer Pharmaceuticals to talk about Kerendia. Kerendia, or finerenone, is the first and only non-steroidal mineralocorticoid receptor antagonist. As of July 2025, it's FDA approved to reduce the risk of cardiovascular death, hospitalization for heart failure, and urgent heart failure visits in adults with left ventricular ejection fraction of at least 40%. Kerendia, unlike steroidal MRAs, is a highly potent selective non-steroidal MRA with balanced kidney to heart distribution and no significant affinity for hormone receptors. By targeting inflammation and fibrosis, Kerendia addresses key mechanisms of cardiorenal disease, and the FDA recognizes it as a distinct drug class different from steroidal MRA. Heart failure, it impacts 7.7 million Americans and is growing. Heart failure hospitalizations heighten death risk and are costly. In the FINANCE-HF trial of over 6,000 patients on standard care, followed for a median of 32 months, Kerendia delivered a statistically significant 16% relative risk reduction in the composite of cardiovascular death and total heart failure events. Unlike for HFrEF, current guidelines for HFpEF and MREF give steroidal MRAs and other medications barring SGLT2 inhibitors a Class 2B recommendation, which is a weak recommendation due to limited or inconclusive evidence, underscoring the need for alternatives in this population. Now, given the unmet need, the strong clinical evidence, and the unique mechanism, we respectfully request the committee to align the criteria for Kerendia with the FDA-approved label, acknowledging the FDA designation of a separate class as a non-steroidal MRA.
Thank you.
Yeah.
Any questions from the board? All right, thank you, Dr. Patel.
Thank you.
Craig, I don't want to butcher your last name.
It's okay. Hi, everyone. I'm Craig Washington. I'm a director with the Field Health Economics and Outcomes Research team at ASI. Thank you for the opportunity to speak at the DUR meeting. I would like to highlight two things. Number one, Leqembi, which you just talked about, is indicated to treat people with early Alzheimer's disease, which includes mild cognitive impairment or mild dementia stage of the disease. It's mostly utilized in the Medicare population and is not a high utilization drug within Medicaid. The current reauthorization criteria for Leqembi requires either a follow-up amyloid PET scan or a CSF test via a lumbar puncture after the 7th dose of medication. Leqembi is dosed IV every 2 weeks, and based on the criteria, patients will be coming back just 3.5 months into starting treatment to look at amyloid levels. I understand you're trying to standardize criteria between the products, but these products are dosed differently, have different mechanisms of actions, and studied differently in the clinical trials. This is an inefficient use of high-cost invasive procedures at a time frame that's just too soon. We would like to request that the DUR board remove the after the 7th dose of medication language under the Leqembi reauthorization criteria. The other thing I wanted to highlight just real quickly is that in May of this year, the FDA cleared for marketing the first in vitro diagnostic device that tests blood to aid in diagnosing Alzheimer's disease. The LumaPost G p-tau217 beta amyloid 42 plasma ratio is for the early detection of amyloid plaques associated with Alzheimer's disease in adult patients aged 55 years and older exhibiting signs and symptoms of the disease. This new test provides a less invasive, less costly option for amyloid confirmation, reduces the reliance on PET scans, and increases diagnostic accessibility. Thank you for your consideration to these 2 points.
Any questions or comments from the board? All right. Thank you, Craig. Next up, we have Ryan Miller for Sephience.
All right. Thank you so much for the opportunity to speak with you today. So I'm Ryan Miller. I'm a genetic counselor that works in medical affairs at PTC Therapeutics. I just went over the policy for the PKU class of drugs, and I just wanted to make a couple comments. The first is that, when considering previous failure on sapropterin, it's 30 days within the past 60 days. I will say that many patients failed sapropterin many years in the past, and that is typically based on genotype, so that would not change. And so I would think that a failure at some time in the past, even if it was not in the past 60 days, would be sufficient. And then also just want to mention that we had 27 patients in our phase 3 trial who switched from sapropterin to sepiapterin, and they saw a 48% reduction in their blood Phe levels when switching from sapropterin compared to their levels on sepiapterin. Also mentioned that we had a phase 2 trial that showed sepiapterin was results in greater Phe reductions than sapropterin. And then we recently completed a phase 3 head-to-head trial that showed that patients on sepiapterin had a 70% greater reduction in their blood Phe levels compared to when on sapropterin. So just wanted to make sure you're aware of all those data points, and thank you for your time today.
Thank you. Any questions from the board? All right, thank you very much. That takes us to the end of our public comment then. Any other questions, comments, concerns, anecdotal stories before we end today?
I have one just question, comment to the discontinuation. Xifaxan is no longer going to be rebating on 10/1, and I think we have a pretty big impact. It sounds like potentially Anthem does. There is a patient assistance program, so I know that's not SPDL, but I think that's kind of that's a big impact that we don't usually see.
No, and I've heard, I don't know if you all have heard, but Xifaxan, the patient assistance program asks if they have Medicaid coverage, like Medicaid insurance coverage, and if they answer yes, it will tell them that they cannot receive patient assistance, but in reality, they don't really have Medicaid coverage of Xifaxan anymore. So the manufacturer is aware. I don't know if they're going to update the wording or not. And it sounds counterintuitive, but we have to kind of tell people to say, no, they don't have Medicaid coverage because they don't have Medicaid coverage of this particular drug. And that is the only way they will get accepted into the Medicaid, into the assistance program. So I throw that out to you as an FYI to any of you who maybe know people who are prescribing Xifaxan. We're going to make sure to, I think, probably should send things to the call center so that they're aware and that they can also communicate that information should somebody not be able to get through the patient assistance program. Good point. Thank you, Monica. Any questions on that? There has been outreach already to them as well to try and add back into the Medicaid program, which is what they have come back with and said, we don't plan to do that, but we will cover your people through our patient assistance program. So theoretically, they should all be receiving patient assistance. All right. Any other comments? All right, Dr. Ra, I will turn it. Well, wait, I've got to get one comment. Amy, what is it today? If you couldn't hear that, she said happy Friday. All right, now I'll let you turn it over for our adjournment.
Okay, thank you to everyone for attending, and please enjoy your weekend. We will adjourn this meeting.
Thanks, everybody. Have a great weekend. Bye-bye.